It turns out that the abortion pill has 4 times as many complications as a surgical abortion. And because it is increasingly difficult for the abortion industry to find OB-GYNs or other doctors who are willing to perform surgical abortions, they are promoting medical abortion to women.
Hello, I'm here today, very excited to be with Dr. Ingrid Skop and to have an important follow-up conversation about the hot topic of chemical abortion. Dr. Skop is currently Senior Fellow and Director of Medical Affairs for the Lozier Institute, and she has a long experience of over 25 years of practicing as an OBGYN in San Antonio and doing some research. So she brings this, not only the scientific experience and expertise, but a long experience of practicing helping women. So I'm very excited to be here with Dr. Skop this morning, and Dr. Skop, welcome. Great to have you.
Thank you. I'm so excited to be here.
Well, we are too, and I think there's so much information, as we were just talking about, so much misinformation that is going around these days about this topic that we really need to set some records straight, and I'm looking forward to our conversation about that. But I want to start with more about you, and if you could, add a little bit to what I said about your background, and how did you come to where you are today?
Thanks. So like you said, I've been an OB-GYN in San Antonio for 25 years. And during that time, I've seen many women that have been hurt by abortion. I've cared for many in the emergency room who came in hemorrhaging, often needing surgery. And so this began my interest in this because, as your viewers may have seen, the abortion industry tells us that medical abortion is as safe as Tylenol or a shot of penicillin. But it turns out that because we don't have good complication reporting data, we just don't really know how safe it is. So, that's where I got interested. I've done a lot of research. I've done writing and sometimes expert witness testimony for some of the states. And that led to the job transition to where I'm working with Lozier, which is the think tank associated with Susan B. Anthony List. Just trying to help to get medically accurate information out to the American public and also to legislators so they know what really needs to be done to keep women safe.
You mentioned a little bit that you help women after an abortion. Tell me more about your interest specifically about the abortion pill. How did you get more specifically focused, and where you wrote a very, very strong article about that. We're going to talk more about it on the Charlotte Lozier website. But what brought you? Where did you start seeing things about the abortion pill?
Well, it turns out that the abortion pill has 4 times as many complications as a surgical abortion. And because it is increasingly difficult for the abortion industry to find OB-GYNs or other doctors who are willing to perform surgical abortions, they are promoting medical abortion to women. So we've seen really an exponential increase in the amount of medical abortions that are being performed. And so along with that, we're seeing a lot more complications. So that, initially intrigued me, the more and more complications that I was seeing. And I also have seen that in many cases, the abortion providers will tell them, if you have a problem and need to go to an emergency room, don't tell them that it was an abortion. Let them assume it was a miscarriage. And so I found that to happen a lot. And in fact, I was involved in a study with Lozier where we looked at known paid abortions in 17 states, and we found that of the women who presented to the emergency rooms within a month, 60% of them were miscoded as having been related to a miscarriage. So we were able to document what I had seen in the emergency room, that most of the time when this happens, it's not being identified as an abortion complication.
So you personally saw women who had complications from the abortion pill in the ER?
I did. Just to help your viewers understand what the abortion pill is and what it does. It's not the same as emergency contraception. I've found that some people have a little confusion about that. Emergency contraception is essentially a high-dose birth control pill that is taken within 3 days of unprotected intercourse. It doesn't work all that well to prevent pregnancy, but I don't think it really disrupts a settled pregnancy. But medical abortion or chemical abortion, which I agree is a more accurate term, because we think of medicine as being something that promotes health, but of course these chemicals are promoting death. A chemical abortion is provided with 2 medications. Mifepristone has been tightly regulated. We'll talk more about how that's not the case so much anymore, but it blocks progesterone. It blocks the hormone that sustains the pregnancy. Misoprostol is the second component. It's given usually 24 hours or 48 hours later, and it induces uterine contractions. So mifepristone kills the baby, and misoprostol causes labor. But it doesn't always work. And if it doesn't completely push out the tissue, the women tend to continue to bleed. About 8% bleed for longer than a month. But most women will bleed for usually a week or 2. Often it's heavy, and that's when the pills are working the way they're supposed to. But if they don't work appropriately, and good studies tell us that probably 1 out of 20 women cannot pass all that tissue on her own and will require surgery.
And so what happens, and I read in your article, some data showing 5 to 6% of women who use this process actually end up in the ER. What happens what is the process, and what have you seen really when this happens?
Yeah, they can go back to the abortion provider, although it's not clear to me how much they're warned that this could happen, because I think most of them are not aware that complications are higher with a medical abortion. If they knew that, I think many women would probably choose a surgical abortion. But it's being promoted to them, because a lot of abortion clinics don't even provide surgical abortions anymore. So this is easy for the abortion providers. All they have to do is send the woman out the door with some pills in hand, and they make $500 or $600 for their trouble. But when they cannot pass the tissue on their own, again, if they go back to the abortion provider, they'll be charged for another procedure. So in many cases, they come to the emergency room. If they have health insurance, the health insurance will cover the treatment there. Usually it requires a surgery, a minor surgery, we call it a suction and curettage, to remove the tissue completely. And so that's where I've been involved in what I've seen. Sometimes they lose so much blood that they need a blood transfusion. Sometimes the presence of the dead tissue in their uterus leads to an infection. So occasionally women need to be admitted for IV antibiotics. And we actually know that mifepristone impairs the immune response. So of the deaths that have been reported after medical abortion, many of them have been related to a very unusual bacteria called Clostridium sordelli, which a normal immune system can usually withstand. It's a common organism. So on occasion, women have worse complications. On occasion, they need a hysterectomy. On occasion, they die from the medical abortion pills.
I want to back up a little bit and go back a little bit to the history, because you mentioned something about regulations and how that has changed. Could you describe a little bit the history of this pill? Because it's not very old. It only started being promoted or used in the US in 2010, I believe, right?
Well, actually, even earlier than that, but the story is interesting. It was known as RU-486 when it was initially manufactured in France, and President Clinton and the Population Council requested that. It was very unusual. They said, please bring it to the United States. And so it was really a population control measure that was the motivation for it to be brought here. But because it was known that sometimes really significant adverse events occurred, it has been regulated tightly. The mifepristone, the first component, has been regulated tightly by the FDA. The protocol is called a Risk Evaluation and Mitigation Strategy, or REMS. And among other things, it requires the provider to register to be an abortion provider. So as an OB-GYN, I can't even prescribe it. Thankfully, I wouldn't do it. But obviously, removing that type of a restriction would put pressure on doctors who have moral and ethical prohibitions against abortion. It would put pressure on them to prescribe this. It was to be given in the presence of the provider, so the doctor needed to do an ultrasound and find out how far along the woman was. Initially, it was only approved up to 7 weeks. That was extended to 10 weeks gestation in 2016, because the further along it's used, the more likely it is to fail. The doctor needed to make sure that it was not a pregnancy in another location, like an ectopic pregnancy in the tube. And the standard of care has always been to check a woman's blood type. If she's Rh negative, there's a standard intervention that's given that's called RhoGAM. That's a shot that prevents her from potentially forming an immune response to future children. So all of those things were done under this regulation. But unfortunately, as we've seen, the COVID pandemic has been used as an excuse to do a lot of really bad things. And in this case, it was used as an excuse to remove the in-person supervision. So currently, it can be prescribed by telemedicine. It can be ordered over the internet. It's illegal in many states, but that doesn't stop it from happening. And so women are assuming they know their gestational age. They're assuming that their pregnancy's in their uterus. Nobody seems to care anymore about the blood type and whether RH needs to be or RhoGAM needs to be given. And so it's very much unsupervised right now.
So to kind of summarize, we have the initial approval under President Bill Clinton in 2000, right? So the FDA approves the abortion pill at that point with some very specific rules about the need for a presence of a doctor, the ultrasound, so a whole process to ensure some safety, right? And then in 2016, things change already, right? So that's when the number of weeks this could be used for goes from 7 to 10 weeks, right? Which increase the risk, because as you said, the longer you wait, the higher the risk of a failed abortion. And then, did they still have the supervision requirement at that time?
They do still have the requirement that a doctor must register to be the abortion provider. They used to mandate complication reporting, but a FOIA request and an analysis of that data showed that probably less than 5% of the expected complications were actually reported. So even though there was a mandate, a legal mandate, it wasn't done. But despite that, in 2016, when they changed the requirements, they said, no longer do you need to report complications unless it kills the woman. So yet another layer of oversight was removed. The goal, and this is, if you look at Guttmacher Institute and read some of the writings from many of the abortion advocates, they are very straightforward that their goal is eventually over-the-counter provision. So they want to remove all of the restrictions, and they've just been whittling away at them over the past several years. And when that happens, the horse is out of the barn, and we are going to have no way to keep women from accessing these pills. There's going to be no oversight. There's going to be no way to know how frequent complications are. States that pass legislation, the things that happen in the absence or in the overturn of Roe won't matter, because women can circumvent the system. And in fact, right now there's a website that's called Plan C. And if you look at it, it asks what state you're from, and it tells you how to circumvent your state's laws to get these pills. So that's where we're going, and when that happens, it's going to be very dangerous for women. But we're going to have no way of stopping it.
And you mentioned in your article too that so there's removal of oversight and reporting requirements in the U.S., but then we see in other countries where this is reported, the data shows the risk, right? So like in Finland, can you talk a little bit about what they find out in Finland?
Yeah, so again, the problem in the United States is most of the time insurance does not pay for abortion, so we don't have any way to link the actual abortion procedure and complications that are paid for, because there's two separate payers. There's privacy concerns, so it's really difficult to get good data. But Finland has actually some excellent data. So they pay for the abortions, they have a single payer healthcare, so they know every medical procedure and every medical event that occurs. They're meticulous record keepers. And so a study of 42,000 women in Finland demonstrated 4 times the complication rate of chemical abortion. 20% of the women who had chemical abortions, and this was actually less than 7 weeks. This wasn't even up to the 10 weeks that we talked about. 20% of those women had complications. About 6% of them had hemorrhage and required surgery. So good data internationally tells us that these drugs are very dangerous for women. A further thing that's happening internationally, which I think is unconscionable, is that in countries that have abortion restrictions, abortion advocates are promoting the idea that millions of women die worldwide from illegal abortions in countries with restrictions. And so they're working actively to overturn the laws in those countries. And many of those are Latin American Catholic countries. I think we've seen in African countries that are very religious. So they're trying to put their own agenda. It's a population control agenda, and I would say eugenic, on these countries that have moral objections. And when the countries don't change the laws, they're bringing in these pills, again, the same way they're doing it here by mail order. Sometimes the NGOs are bringing them in on the ground. If they can't get mifepristone, they're recommending only misoprostol, the second component, remember, the one that causes uterine contractions. But misoprostol does not work well. Probably 1 out of 4 women who use misoprostol in the first trimester require surgery. In the second trimester, it's as high as 40% that require surgery because that medication does not get rid of all the tissue. And they're doing this in countries that have very poor blood banking, very poor access to emergency care. It's not something that has been that a lot of people are aware of, but in my mind, it is the most immoral thing I can think of to try to bring in abortion to these countries and to bring in these very dangerous methods and promote them as if they're safe.
Yeah, it sounds horrible. I mean, we had Uju Ikeocha speak for us last year, and she was talking about the push of contraception and abortions in Africa specifically, and how women are being delivered and drugs in little remote villages, right? They don't even know what. There's no medical oversight. They don't know what really they're taking, and it's tragic because who knows who's tracking the data about these women having all these problems. So it's a absolutely horrible.
Yeah, and the WHO presumably tracks, but they're pro-abortion. They've said it before, and they use the Guttmacher Institute researchers, so they basically find the answer that they want to find. But when you look at their data, they do it by very broad surveys. They'll look at 13 countries and they'll ask their fellow ideologic NGOs how many women they think are dying. I mean, there's no statistical accuracy at all to it, but they promote the idea that if it's illegal, it's deadly, and that if it's legal, it's extremely safe. And the truth lies in between.
You mentioned ectopic pregnancies. Could you describe a little bit more about what happens there? What is the risk, and
Sure.
how is the pill risk for this?
So about 2% of pregnancies do not make it all the way to the uterus before they implant. They end up implanting usually in the fallopian tube, although it can happen that they implant other places as well. And mifepristone, because it blocks progesterone receptors in the uterus, does not have an effect on a pregnancy implanted in the tube. So that pregnancy can continue to grow, and eventually it will break open the tube. It'll cause it to rupture, and it doesn't have the ability to stop the blood flow. And so torrential bleeding can occur. It is a very common cause of maternal deaths. Probably as many as 10% of maternal deaths are related to ruptured ectopic pregnancies. And so it's crucial that that event be ruled out before a woman is given a chemical abortion. In fact, one study showed that if a woman had an undiagnosed ectopic pregnancy and took the chemical abortion pills, she had a 30% higher likelihood of dying, because when she experiences pain, she's going to think, oh, that's what the pills are supposed to do. She's not going to recognize that's not normal and your life is in danger. And in fact, Planned Parenthood just last month published a study looking at pregnancy of unknown location. So if an ultrasound's done and we can't tell, maybe it's too early, is it in the uterus, is it in the tube, they recommend you giving the chemical abortion pills anyway. So that's how little regard they have for women's lives, that they don't seem to care if an ectopic pregnancy is present. And half of the women with ectopics have no risk factors, so there's not a way that you can tell for sure, based on her history, whether she could have an ectopic.
So this is another reason. Like, if you think of countries that have less medical systems, again, the provision for this type of situation is probably overlooked.
It's overlooked. I'm not going to say it's intentional, but I don't see how they can't see that these recommendations are going to hurt women.
Yeah. So now, okay, so the situation today. What do you see is where are the most recent development in this area, and where do we go from there?
Well, of course, we're all excited about the possibility of the overturn of Roe, which will bring the question of abortion legislation back to each individual states. Quite a few states are aware of the problem with medical abortion provision, and so quite a few states already have passed laws trying to bring the supervision back and to mandate complication reporting. Again, it's very concerning, and it's clearly the case that the abortion industry is going to try to continue to promote the mail order abortions, which circumvent the legislation. So I think, for me, the priority number one is to educate the American public about this problem. The legislators are being educated, so again, it's being discussed in the halls of law. We really need a way to track complications better, and there've been some ideas about how that can happen, but again, right now there's not a good way on the ground to track complications, and most doctors, I've discovered, are not aware that if they don't report the complication, that it doesn't get reported. So I think people naively assume there must be systems in place to track complications, but there really aren't. I think in the coming months, we're going to see organizations prioritizing the care of women. We know that there's 2,700 pregnancy care centers in this country that already have been doing that, but I think we're going to see them become more visible, and hopefully Americans are going to recognize that there are resources available for women in crisis pregnancies. That's something the church needs to be involved in, even more than they already are. So hopefully women, when they encounter these pregnancies, their initial response won't be look online to find an abortion pill, but will be to avail themselves of the resources and hopefully we can bring men on board and get them involved in caring for the women in their lives and the children. But it's hard. I mean, there's the potential for a lot of bad things to happen. But education, I think, is the very first thing that we need.
What would you encourage doctors to do who are listening to this?
Well, I think doctors need to make themselves more educated as well. Unfortunately, most of the mainstream high-profile medical organizations have statements that show us that they are pro-choice or in many cases pro-abortion. The fact that the American College of Obstetricians and Gynecologists keeps revising their recommendations to allow these dangerous medical abortions tells me that they've lost the focus on the health of the patient, and perhaps other ideology is driving their recommendations. But doctors on the ground just need to recognize that the data is not as straightforward as they've been told. It's not safer than penicillin or Tylenol. It is actually dangerous to women. And hopefully more awareness among physicians, particularly OB-GYNs, will bring more complications to be reported so that we have better data and can show women this is not a good thing for you.
So what is happening with the new way of marketing these pills, the future way of marketing these pills?
Well, like I said, the ultimate plan is over-the-counter pharmacy provision, independent of any medical oversight at all. And already we're seeing a phrase, menstrual regulation. So what that will do, it will market the chemical abortion pills to women who have a delayed period, but it won't require them to do a pregnancy test first. So they can tell themselves, I'm just taking these pills to bring on a missed period. They're probably pregnant, but they can live with the knowledge that they don't know and that they didn't perform an abortion, that it was just a pill to bring on a period. So to take away the stigma, that's kind of one of the next frontiers, I think.
And it's still the same drugs?
It's still the same drugs. It still has the same horrible side effects. There are many ways to bring on a missed menstrual period that are not nearly as dangerous as chemical abortion pills.
And any closing message for our listeners, couples, women who are, wanting to help these women, really, because I think it's an issue of how do we care for these women who find themselves in these situations.
Yeah, I mean, it's again, just awareness, supporting your local pregnancy resource center, educating yourself. I work for the Charlotte Lozier Institute, which has a lot of papers available on their website. I've also affiliated with the American Association of Pro-Life Obstetricians and Gynecologists, which have some excellent resources on their resource tab. So any question you might have, abortion for the life of the mother, ectopics like we talked about, perinatal hospice, how do we care for women who unfortunately may have to be delivered of a baby that may not survive? It doesn't have to be an abortion. That's a fallacy that people are told. As a woman's OBGYN, I can deliver her by induced labor or by C-section. I can care for her in her crisis, but I don't have to kill her baby to do that. So support for the people doing pro-life work and educating yourself so that you know what the truth is, I think, are the two important things.
Well, Dr. Skop, thank you so much. It's been a pleasure talking with you today, and God bless you with this important work you're doing. We're excited to see you, influencing many people, especially people who are thinking about the laws and regulation to protect women better. So thank you again. Great to have you today.
All right, thank you. I appreciate it.